Good afternoon, everyone. Thank you for joining us for our afternoon session on our fourth virtual North Country Telehealth Conference day. My name is Katie Cook. I'm the Telehealth Project Manager at Adirondack Health Institute in Glens Falls, New York. All of the sessions that you've likely been joining throughout the week are brought to you by the North Country Telehealth Partnership. This is a partnership between AHI and Fort Drum Regional Health Planning Organization based out of Watertown, New York. We have been partnering since 2015 on expanding telehealth throughout the North Country. Today's session is Optimizing Telepsychiatry in a Post-COVID World, featuring David Theobald from Genoa Healthcare and Helen Vanderlyn from Conifer Park. Next up, we want to give a sincere thank you to all our past sponsors. This is the 6th year of the North Country Telehealth Conference, and it would not be possible without all the organizations on this slide, including Genoa. We hope to be able to reconvene in person next year, and just want to give a thank you to all of these organizations that have supported us throughout the years. A few housekeeping items before we kick off today's session. You have been muted upon entry and your video has been turned off, so please ensure that those two things remain off for the duration of the session. To avoid an echo on your end, please choose either the computer audio or phone audio. Having both on could result in an echo on your line. For optimal viewing, we do recommend using side-by-side mode. To activate this, you would click on View Options at the top center of your screen and choose side-by-side mode from the drop-down menu. Please use the Zoom chat function to submit your questions and comments for the presenters or AHI staff. We will ensure that all questions are answered in the Q&A portion at the end of the presentation. Lastly, all of our presentations are being recorded, and the slide decks will be shared on our conference website along with the recordings by October 9th at the latest. So now I'm going to turn it over to David and Helen. So David, you can go ahead and share your screen.
Thank you, Katie. It's a pleasure to be here. I'm going to I'll introduce myself and Helen first, and just say that we have had the pleasure of working with Katie and her team for several years now, and it's been a pleasure to see telehealth grow so robustly even before COVID took off. And so, well, just to introduce myself, I'm a senior telepsychiatry partnerships manager at Genoa Telepsychiatry. We're the biggest outpatient telepsychiatry provider in the country and the biggest in New York State as well. We've been working for about 3 years now since the regulations were liberalized quite progressively, and have I feel like I thought it was important to do this presentation because we've learned a lot, particularly over the last 9 months, and wanted both from the clinical practice and regulatory front, and so and I've appreciated how much we've learned from Katie and her team and other members. So that's why I'm here. And I wanted to, it was very important that I include one of our clinics. So Helen Vanderlyn, Associate Executive Director of Conifer Park, is joining me, and she's going to be talking in more of a fun case study format about how they've used telehealth more broadly, both inpatient and outpatient. We will definitely have ample time for questions. I think we'll have at least 15 minutes. So look forward to that. If it's possible to hold your questions to then, and we will be sure to address them. Okay. So the agenda is just overall pre-COVID, shifting to telehealth, and then with COVID, what's changed in regulations at the national state level, and then our case study with Conifer Park. So this is national data from from community health centers, both community mental health centers and federally qualified health centers, through I think it's through July of this year, but it's probably still held the same. But basically, 90% of public health clinics now use telehealth, and the 10% that did not are very much the exception. It is the predominant form of mental health care delivery. And actually, I'll go to the next slide, and you'll see that, in fact, psychiatry, 90% of psychiatry sessions and 70% of therapy sessions are done by telehealth. So far and away, mental health is at the vanguard of telehealth, and it's much more broadly accepted. We'll talk about kind of what that means, but just there were some gains in primary care, but and even less so in specialty medicine. But really, what we're talking about is just widespread growth of telemental health. And here's some of the top line trends I alluded to clinically. That the and this data, I would encourage all the agencies on the call to share their own results with Katie and her team, because it's helpful when we advocate at the state and national level to continue the liberalization ongoing. We'll talk about how that's already started, but just to make sure, especially CMS addresses this, is important to share the success stories. So first off, client utilization, the no-show rates have dropped. Typically to 5 to 10%. So versus a norm of 20 to 30%. So substantial improvement in a no-show rate. That's a definite benefit. Client behavior, most started by phone, but most individuals are now also using video. And there's no material differences that have come out by age or acuity. And I'll share one anecdote in New York. It's in New York City, but with the senior population, I'm on the board of an organization called SPOP, Service Program for Older People. It has 20,000 seniors, mostly in their 80s and 90s, so really older folks. And they had a survey that was done, and vast majority, 85%, were pleased with the shift to telehealth. So really, just an anecdote that it's not something that has really differed dramatically by age or acuity. It's really more just a function of getting the proper bandwidth, which I know we can talk more about. But in terms of client acceptance, the video has been very well received. Lastly, in terms of provider behavior, now there's a lot more psychiatric nurse practitioners and psychiatrists who are just comfortable treating clients at home, recognizing that they'll have to rely on a recent physical or clinic visit for vitals and labs. And sometimes, of course, that can be a challenge because there may be a delay from when the client has last gone in for that. So I am sensitive to that. We need to keep those current. But assuming that can be done, a lot more providers are comfortable that, yes, I can see my clients in their home where it's more convenient for them, and I may actually get some added insight into their behavior at home. So that from the provider side, another real benefit of telehealth coming out of the epidemic. In terms of some learning on care delivery overall, just, I guess, summing up what was described in the previous slide, we can say both clients and providers realize the convenience of telehealth and will maintain it as an option. Video versus voice, providers especially will maintain a strong preference for video to be able to get the nonverbal cues of their clients. Clients, I guess, for the most convenience, although they're comfortable with video, it is most convenient to just do voice. So there is still some prodding of clients to say at some interval, hey, I really do need you to get in the house where you've got a good Wi-Fi connection, so we can see you live or how you're doing, or perhaps come into the clinic and be seen there with providers still remote. On-site visits. For psychiatry, clients will still need to come into the clinic for labs and vitals. So that is something that almost all the clinics that we're working with have reopened just to allow for that. And then in some, there's a clear benefit that overall, you step back with these changes, with the lower no-show rates, there's more people getting more frequent care. Now, I'll shift gears to talk about the regulatory changes. First, at the national level, great news, really, that the state licensure regulations have been waived. It's such a barrier to care in the U.S. We're so fragmented. And in New York, it's been honored as well. So there's no longer a requirement that the physician have a current New York license. The exception is that is from the HHS across the board, but it also holds true in New York. As long as they have a license from another state, they can start practicing. The client location requirement has been waived in New York. That was already, there were already broad exceptions granted, but at a national level now, there's been all requirements for where the client is located have been removed. And this applies for Medicare as well. So whereas previously Medicare was only allowed in rural health provider shortage areas, now in Medicare in urban areas too. So both Medicare and Medicaid have removed that restriction. That's excellent news. As I mentioned, we're involved in advocating that flexibility be continued ongoing with Medicare as well as Medicaid. I welcome everyone's support in making that happen. In terms of HIPAA, you probably heard that that has been relaxed. The OCR will not enforce HIPAA regulations, so pretty much, at least during COVID, all the major public platforms for video are allowed, including FaceTime and Facebook. There is I know for clinics, best practices, many still prefer to just use the HIPAA compliant versions, which are frankly not that expensive, whether it's Zoom or Doxy or Genoa has a free one. They're quite accessible too. Probably the big thing is with phone only, that is that's not is easy to police on HIPAA compliance. So we're hopeful that this will be clarified, that there's some frequency of video visits that are required to make sure we get a clean read on where the client is. Okay, then on controlled substance prescribing, here again, liberalization. There was some ambiguity under legislation before about prescribing controlled substances. The Ryan-Haight Act required an in-person evaluation. Fortunately, in almost all states, including New York, that's been interpreted to mean that it doesn't have to be a psychiatrist, it has to be a clinician who is verifying that the client is appropriate for remote care. So there's a physical exam that's happened in person. So that was addressing the ambiguity before, but now, since in many cases the client can't even come in to see any type of clinician, the regulation has been waived entirely. So there's no prior in-person evaluation required by anyone. However, there is a requirement, this is worth highlighting, that the a tele session be video as well as audio for at least initiating the prescribing of controlled substances. So that's just to watch out, because I know sometimes in practice, as I alluded to, it's hard for clients to set up that video connection, and maybe it might default to a phone only, but really to comply with the regs and of course best clinical practice, you really do need a video connection when you're initiating prescribing of controlled substances. Now, to kind of summarize which flexibilities are here to stay, we think that everything that is with video is here to stay. Whether phone only will be allowed at a federal level is unclear. New York State, as you probably know, has legislation that's been signed by the governor that allows for ongoing reimbursement of phone only. So it's nice to have that flexibility. I think because of the DEA issue at the federal level, it's less clear. There will probably be some minimum threshold or frequency of video check-ins. But the good news is that, that regardless, it's very unlikely that there will be a return to mandating in-person services. What are we hearing from Congress? We are, as you probably have heard, there's massive support from both parties, very encouraging it this year, but there's massive support from both parties with letters and hearings, letters to CMS that the flexibilities need to continue, hearings to actually go out and just clarify with laws that telehealth needs to be accepted both by commercial and public payers. Ryan Haight should be clarified to have an exemption for psychiatry. These are happening, and in fact, Senator Murphy from Connecticut, he just introduced a bill to open up licensing, so have statewide reciprocity of licensing to continue as well. So that's pretty radical. I think it makes sense, but it just gives you a sense of the scale of liberalization that's happening. Where do we go from here? We just continue to use wonderful forums like AHI to share success stories, share learning, so that we can let our regulators and legislators know at the state and local level how this is playing out in practice and how critical it is for expanding access to care. So that's what we're really focused on doing. I'll give a few, this is probably less news to folks in New York State because of the excellent work that AHI has done in sharing the New York landscape. But just to quickly go through this, there is clear exemption for requiring a New York State license, as long as the provider is in good standing in the state where the license is. It is fine for them to practice in New York. The originating site is removed for New York Medicaid. No limits for the state of emergency whatsoever. Telephone-only services are allowed, and as I alluded to, the audio-only telehealth coverage is extended post the public emergency by new legislation. What we're seeing from flexibilities is that New York, very much like the national level, will continue. New York's actually been out in front, so we're very encouraged, and I think it's important that we just continue to talk with the regulators, because what we're doing in New York and especially in the North Country, it's really in many cases ahead of what's going on in the rest of the country, and so we kind of have an obligation to share our learning more broadly. I've been really pleased working with our clinics. Well, that's a nice segue, I guess, to introducing Helen at Conifer Park. Just the innovations that have occurred at each clinic level for accommodating programs across a range of services. And what you'll hear from Helen is how telehealth is being used much more broadly than just psychiatry, but I think it ties back to, it's really the total care team and total package of services that constitute mental health. It's all pretty much amenable to telehealth, and it's neat to see it reaching another level in practice. So with that, I will introduce my co-speaker, Helen Vanderland, the Associate Executive Director at Conifer Park.
Eva, thank you very much. Nice to see everybody. I have my last year's telehealth mug here representing for all those of us who were at the conference last year. And thank you to Katie. So Conifer Park, who are we? What do we do here? Conifer Park is, we're based here in Glenville, New York, a private inpatient facility. We have 32 wooded acres. We provide detoxification and inpatient rehabilitation services. We take referrals, admissions from all across New York State, Buffalo, Plattsburgh, New York City, the whole gamut. We also have 6 outpatient facilities: Glens Falls, Liverpool, Plattsburgh, Rochester, Schenectady, and Troy. The programs you see with asterisks are also opioid treatment programs, which means we can dispense methadone and buprenorphine at the medication window. We actually have a great relationship with our outpatients in terms of being able to induce on MAT and then get them to their outpatient level of care on their MAT. We've been providing treatment for substance use disorder patients since 1983. We are licensed by OASIS, certified by the Joint Commission, and again, we provide medication-assisted treatment at all of our levels of care. You can go to the next one.
Okay.
I don't know if I have that kind of power or not.
Yeah, sorry. Ignore the guy behind the curtain.
So what have been some of our challenges during COVID? We functioned, and just as a broad overview, as you can see, having both inpatient and outpatient levels of care, our response during COVID has been broadly different in between those levels of care. You know, you don't do inpatient services remotely in a lot of ways, right? But our outpatient service is certainly readjusted. So every level of care had its own level of adjustments that we made using telepractice during the COVID crisis. The backbone of addiction treatment, of course, is group therapy, right? Everyone gets in a group together, they process things. The closer people are together, of course, we know that's contraindicated in every single way in this moment in our lives. So, you know, even with social distancing and patients wearing masks, it's very difficult to engage in group counseling. You can't even see the expression on the peer spaces in the room that you're in, so that does create a significant challenge for us. Our ongoing challenge, of course, is always how to coordinate between our inpatient and outpatient services, especially since our outpatient services, we have one in, you know, within probably 10 minutes from our inpatient program, but we also have one 3 hours away from our inpatient program. So how do we coordinate? And we focus here on our certified peer recovery advocates, because we believe they are a phenomenal link between levels of care. As all of you healthcare providers know, getting our patients between higher levels of care and to lower levels of care successfully is one of our biggest leaps, if you will. And also, most of our patients have co-occurring psychiatric disorders. So what are our strategies to make sure that we're treating those appropriately? I will tell you, when initially COVID struck, if you will, we did have some providers who used to come into this building who took their option to not come into the building. And of course, we still have patients that we're serving. So what do we do in those situations? You can go to the next one. Okay, so some of our patient reactions. On an outpatient basis, we conducted therapy sessions, individual and group, via telemedicine. Sometimes we're able to use the video format. Sometimes it was audio only, as David was discussing before. So how do we adjust with that? Some of our patients, the feedback they got was they really missed that just real in-person discussion. They understand what we needed to do. They were respectful of it, but it just didn't feel the same. Some of them kind of got a little bit isolated. One of the benefits of group therapy is sort of that in-person connection. So there was a little bit of that. What I will say is a lot of our patients really did like the telemedicine option. They felt it was certainly safer from a COVID perspective. And also, one of the things that I don't think we thought about, we had been certified, we've done all the waivers for telemedicine before COVID hit. Not that they're applicable these days, but it was good to sort of have all the regulation, all that kind of down pat. What was really, traditionally from a mental health and substance use disorder philosophy, there was a belief that we got to have the patient in front of us to do care, right? And there's certainly something to be said, and David alluded to some of these things also. Certainly a set of vitals is a good thing, a urine screen's a great thing, doing a good mental status exam is a good thing, but a lot of patients, if they're trying to access care initially, have barriers to coming into treatment that go beyond what their motivation is. They have childcare issues, they have transportation issues. So what we found is we were able to get some better engagement from that category of patients who might have otherwise really struggled to engage, taken a long time to engage, because those barriers were effectively taken away. Not that we recommend having your child right next to you during your group therapy experience. However, you're getting something out of that process. And also we have a population, group population at Conifer Park, kind of a professionals population. This is a group of people who have degrees, who have full-time jobs, who there's still a big stigma around addiction treatment. Coming to a clinic, there was a lot of concerns in doing that. Obviously, there's scheduling issues. I don't know about any of you, I don't always walk out the door on time when I'm supposed to leave. So being able to organize group therapy sessions via telemedicine actually was much more effective for their schedules and just how they socialize and how they do meetings in the first place. That group had some familiarity with conference calls and that sort of thing, so it was easy for them to transition it, fit much better into their lifestyle to use telemedicine. Move on to the next. In terms of how we coordinate between our inpatient and outpatient sites, we're building a peer warm handoff. So for example, again, when we had a patient going to and from within the Glenville, Schenectady area, maybe we would have the certified peer recovery advocate come into our building to do some coordination. But we have patients, we actually have a lot of patients from Monroe County. We have patients from Plattsburgh, from the North Country. So we're not always, we certainly weren't able to, get the SERPAs in the building for those situations. So we're really in the process of, and it's being developed all the time, of making sure we have that video warm handoff with the SERPA. It's actually, it's like a 10 to 15 minute conversation. It's very brief. It doesn't take up a lot of time. They're able to, see the actual entire face because that person is in a secluded environment. For someone who's going to be at their receiving clinic, they do a little tour of the area. Hey, this is what it looks like from the outside. These are the people you're gonna be working with. And it just gives somebody a great impression of what their next level of care could look like, and knowing there's someone waiting for them on the other side who really cares about their ability to make it there. So that's been really interesting to see. Move on. So in other transitional news, we also, as an inpatient, outpatient kind of a hybrid program, have really emphasized work with families. So what we used to do is we used to ask families to come into our building every Wednesday and basically host the families for the entire day. We had one person assigned to them. We would feed them lunch. Who doesn't like lunch? We would do education. We would do breakout therapy sessions with family members and the therapist, but it was mostly kind of this big group presentation. So that went away. During COVID, we have a no visitors policy, as you can imagine. So the benefit, I think, of being able to transition this into telemedicine is that we can involve families who are from further away. So for example, not every family who comes from Rochester can show up at 8 o'clock in the morning on a Wednesday and just drop everything that they're doing. What we're able to do with telemedicine is work around their schedules. Okay, so in terms of telepsychiatry, what we found when we looked at the data on our inpatient basis, that 75% of patients admitted to our inpatient programs demonstrate some level of a co-occurring disorder. That number might seem a little on the high side, but for this level of care, it's really pretty common. Those disorders range from depression, situational depression, all the way up to delusional disorders, paranoid disorders. We have an opportunity once we stabilize patients from their substance use Sometimes that's a detox stay. Sometimes that's an induction on MAT. For a patient newly into recovery, it's a very stressful, it's anxious, it's depressing. A lot of those symptoms really mimic early recovery and mental health. So we spend a little time trying to like sort out those differences. Once we get them stabilized, potentially on an MAT or tapered off something, then we can look at someone and say, you know, what's really going on from a mental health perspective? And we see everything, as I said before: depression, anxiety, PTSD, trauma, bipolar disorder, schizophrenia, delusions. You know, bring your DSM and we got it, basically. What we also do is we make sure patients are appropriate for telemedicine. So a patient with active psychotic symptoms, we generally try to reserve those patients for a provider on site. And that's sort of for the whole, maybe we don't want the doctor in the TV for the patients who maybe have always seen a doctor in the TV. So for lack of better terminology. Patients with very significant anger management issues, we also think twice about, because there's some people who you really want someone in the room. What we found though is we've actually screened out many fewer people than we think. We are able to work with some of our patients who have some delusional thinking, some psychosis, because they're able to understand the process of who they're speaking with through the telemedicine. So as we've gone through this since March forward, we found we actually haven't had to screen out that many people. And then of course the big question, do our patients respond to telemedicine? Move on here. As a matter of fact, they do. I know that was not a surprise to most of you listening. So what we do for our telepsychiatry folks is everyone has a satisfaction survey. We initiated that because it's part of the pre-COVID regulatory requirements to always do satisfaction surveys for anyone receiving telemedicine services. 95% of our patients who use telepsychiatry on an inpatient basis rated the quality of the overall experience as excellent or good. And that really was striking to us. We believed our patients with a mental health history would feel pretty strongly that they wanted to sit down and talk with somebody. They really want to have that face-to-face experience. And what this tells me is they are getting that face-to-face experience. The person who's on the other side of that telemedicine screen is able to be fully present. They're able to feel fully heard, literally, you know, from an equipment standpoint and from a therapeutic standpoint. And that it's really not, you know, when I compare that number to your overall experience with anything, 95 is a great number to be at. In terms of the provider we worked with Genoa to have here, 98% of the patients rated her care as excellent or good. So they're a fan of those services. Our patients really just want the service provided. For the most part, they're good with a person, they're good with the person on the TV. The most important thing to them is getting their needs met. Of the 345 patients that did receive telemedicine services since March, 6 of them had some issues with connectivity that impacted the session. And most of those were earlier on when we were sort of still working through some of the connectivity things, making sure that everyone involved, our staff and the provider working out of Florida as it happens, were able to do what they need to do in regards to their equipment. So we feel very positive about the experience and that our patients are really getting what they need in a time where we couldn't guarantee them an in-person experience. So it's been really positive for us. Oh, David, I think you're muted.
Thank you, Helen. I guess we can stop the dialogue and go into Q&A. I've got the chat open here if anyone wants to chime in with questions.
Sure. We haven't had any questions come in throughout. That could just be because you covered everything. But yeah, we'll wait another minute or two and see if folks have some questions. Would you say, actually I have a question for you, Helen, and this is one we've been kind of asking a lot of our partners is, what of the regulatory flexibilities that have been granted would you say have been the most successful for Conifer Park and would help you be successful with telehealth going forward?
Sure. I mean, really, as an overall organization, the flexibility around providers and MAT, I think, has been the most valuable to us. The regulations around take-home doses, for example, of our programs, with so many of them being methadone programs, having someone have to walk into the clinic 6 days a week who has, you know, a lot of immunocompromised issues, a lot of co-occurring health disorders, that's really a person you don't want to see face-to-face 6 days a week. So
Right.
really the regulations to be able to give our patients the access to the MAT that they really need to be successful without having them need to come into our building as often as they were, I think has really been critical.
Okay, a question came in from Tracy Leonard. How have you managed care for those with limited broadband data minutes, etc.?
I know for our basis, if somebody we've been very flexible with the type of telemedicine that they've been providing. So if they're not able to use video, we do rely on phone call sessions for that group of people. We also do work with, some collateral resources. We'll say, hey, do you have better internet at your mom's house? So we really get pretty creative with how we respond to some of those concerns. It's really been an interesting learning experience for us, but we truly, between working on those strategies, we haven't had too many patients tell us they really weren't able to connect with us. And actively, we are seeing that for patients who there might be a preliminary issue, we get them in the door, we schedule around a time to make sure that it's the safest we can possibly make it. And that gives us an opportunity, maybe perhaps in that moment, to troubleshoot. And then we can again try to work them on a more staggered schedule.
Okay. David, do you have anything to add to that with other clinics you're working with? You are muted.
Sorry.
That's okay.
No, that's. I think that's fine. I'm just noticing, Katie. There's a question. How do you handle privacy during a tele session? Do you want to answer that specifically for Corner Park, Helen?
So in terms of privacy, we use mostly Zoom and RingCentral software. So we're using systems that are designed to be compliant in that respect. In terms of the telepsychiatry we have in this building, we have a separate room where it's the screen and the patient, and then the door is shut on the outside. So it really does feel like a private session the person is having with the psychiatric provider. There is a staff member located just outside of the door who's coordinating it, getting the informed consent, doing the surveys at the end of it. And if there's, fire drill, or if there's an emergency, they have a staff member to rely upon in those situations. So it really functions very much like a confidential visit would in an office environment with the way it's been set up. That's been congruent with how it's set up with the 830 regulations with OASIS, essentially, that you need to be able to make sure you have a secure setting to do that with. So that's exactly how we set it up in that space.
Excellent.
From the patient side of it, in terms of who else they have around, we don't have a lot of control over that, but I think we have to assume that if they're in a room with somebody else, that they feel some level of comfort with that person over
right. So a question from Suzanne. For those clients who are 80 and older, do they have the resources to use telehealth equipment and the knowledge about IT issues?
Yeah, that's a great question. I can't say I've troubleshooted any personal experience with someone who is older. I know here so I work collaboratively with our outpatient. My focus is here on the inpatient basis. Our staff member is the one who does basically the entire technical coordination piece. So pretty much all the patient has to do is sit down and start talking. Okay. We do rely heavily on our IT department. So if we have a unique situation where a patient's really not able to coordinate or connect, we don't necessarily rely on our clinical resources to help work with that. That's what we got an entire system to add to our call capability to help increase our access to that. So I would say for that population, I would initiate a phone call, because that's probably the way that most of our patients in the older age group would be most comfortable, and then see if we could work them more towards potentially a more live audio video conferencing, or if the phone call is really kind of the extent of their capability from what they understand technology to work.
Okay.
Thanks. If I can add to that, Katie, because I do have, I alluded to briefly, and I actually have a board meeting tonight. So service program for older people on the Upper West Side. It's the biggest seniors mental health program actually in the country. So, and they did a survey which they shared with CMS, so 20,000 of their clients who I'm going to guess at least a third or 80 older. They had 90% plus satisfaction. And how do they do it? I know how they do it is just as Helen described. They'll start with a phone only, but then if there is, they'll just basically triage what the optical is, and they'll have a caseworker just talk through, or a scheduler, just talk through to fix it. Whether it's enabling something on a laptop or a phone, and in some cases they'll actually provide the equipment. But they have not really found it to be a meaningful problem, encouraging.
Right, there's an organization called Older Adults Technology Services, or Senior Planet, up in our region that's focusing on similar work, doing training classes for seniors, teaching them how to use Zoom, teaching them how to access, news on the internet, and they've shifted some of their focus towards healthcare and telehealth, and had a lot of success with that. In speaking with their project coordinator over the last 6 months, a few different times, they've said they really haven't noticed that population's struggled in too many ways, which is nice to hear. Another question came through just to me from Tracy Leonard. Do you utilize a patient portal or secure texting platform to communicate with clients?
We don't at this time use something like that. We have been using the Recovery app as a different type of an effort to coordinate between our outpatients. That's more really like a social support system. So it's not necessarily staff who are always connecting. A SERPA uses that. So it's not always a counseling staff. It's really more about social interactions between patients outside of their normal treatment times. They have resources and support available. We do not have otherwise a portal for our patients at this time.
Okay. Doesn't look like any other questions have come through. So do either of you have any closing thoughts?
I'll let David kick that off.
Sure. No, I guess I would just like to say thank you to Katie and everyone at AHI for as always, the conferences are really worthwhile, but especially this year, despite the added barriers, to make such a rich conference is really helpful. And then as an ask, I just encourage us all to share, and perhaps just using the convenience of being all members of AHI, just to share learning, whether it's results, like I was very impressed personally with what Helen shared, and very hard data that is really compelling. If you have data like that, that's great. If not, just anecdotes that can be shared with the regulators and the legislators. It's so helpful. So that would be my request.
I guess to just kind of step off of that, if you're not, I mean, I'm certain most of the people who are listening here have, dived to some level into the telemedicine realm. And I would say that whatever you think this is where I am in telemedicine, you can probably take it to another step. I mean, we really looked at this from a strong psychiatric need, but the coordination we're finding between levels of care and our ability to sort of just connect all around with various multidisciplines and departments has really been enormous. And I think that's really the future of how we're going to connect people between levels of care. So I really, if you think you've hit that wall of, okay, this is what we do with telemedicine, don't be afraid to get creative and think about your next approach.
Excellent. Well, thank you both very much for taking the time to present this afternoon. Our final conference day is tomorrow. We have one session at 2 p.m. and that is our hot topic session, featuring 3 different speakers doing 15-minute sessions on specific topics like teledentistry, physical therapy and telehealth, and maternal and child health in the telehealth space. So join us tomorrow at 2 p.m. for our final session. And again, thank you, David and Helen, and have a wonderful day, everybody.
Thanks, everyone.
Thank you, Katie. Thank you, everyone.
Bye.
Bye-bye.